Heart failure is an aggressively progressive disease, but for many patients, the daily routine of managing it feels entirely static, taking the exact same pills at the exact same time while the condition quietly advances. The medical community actually has a highly specific, proven roadmap for extending survival, but this roadmap is buried inside clinical guidelines written in a language of acronyms like HFrEF, heart failure with reduced ejection fraction, where the heart muscle is too weak to pump enough blood, and GDMT, or Guideline-Directed Medical Therapy. These guidelines form a strict, tiered playbook. They dictate exactly which medical intervention should be triggered at every specific stage of the disease. But without a translation of this playbook, a patient leaves the clinic with a massive pile of prescriptions and zero context for how to prioritize them. This creates a dangerous blind spot. If you don't know the difference between a foundational medication that keeps you out of the hospital and an optional supplement to help with minor symptoms, you might skip the wrong pill on a busy day. A passive patient simply follows orders until the next checkup. An active patient understands the strategic triggers for escalating their own care. Relying entirely on a busy cardiologist to translate this complex matrix during a 15-minute appointment often leads to missed windows for crucial, life-saving interventions. Surviving heart failure requires patients to decipher this medical playbook themselves. By accurately identifying their current stage, they can dictate their own clinical strategy. The American Heart Association and the American College of Cardiology use a specific grading system to evaluate every heart failure treatment. This is the calculus cardiologists use to write your prescriptions. This chart maps how doctors weigh the clinical benefit of a therapy against the required daily effort and potential risks to the patient. In the top right, we have Class 1 therapies. These are strong recommendations, like SGLT2 inhibitors, medications that help the kidneys remove sugar and sodium, or diuretics that clear excess fluid. The data shows their survival benefits vastly outweigh any risks. These are the non-negotiable foundational pillars of heart failure care. They require strict daily adherence to keep the heart functioning. Moving to the middle, we find Class 2A, or moderate therapies. These offer reasonable symptom improvement, but often require major, sustained lifestyle changes, like strictly limiting dietary sodium to reduce congestion. Down in the bottom left are Class 2B, or weak recommendations. These add-ons increase your daily pill burden and out-of-pocket costs, but the data shows their benefits are marginal or uncertain. Translating these classes transforms a terrifying pile of pill bottles into a clear, prioritized strategy. It allows patients to focus their finite energy and resources on the specific therapies that actually extend life. For most patients, the daily reality of heart failure is stage C. This critical maintenance phase focuses on holding the line against the disease. The core strategy for maintaining this baseline is Guideline-Directed Medical Therapy, or GDMT. To maximize heart function over time, doctors use a process called titration. They start these medications at low doses and slowly, continually increase them over weeks and months. There is a hidden trade-off to this process. Pushing the doses higher requires extreme patience to endure initial side effects, like drops in blood pressure and deep fatigue, while waiting for the long-term survival benefits to kick in. Alongside titration, doctors use aggressive tactics for congestion control. By combining standard diuretics with a thiazide, a secondary type of diuretic that targets a different part of the kidney, they can rapidly clear fluid buildup from the lungs and extremities. Because these fluid-clearing tactics flush out vital minerals, they demand relentless monitoring of kidney function and electrolytes, often managed through frequent telehealth visits. Success in stage C is an active, daily grind of medication adherence and remote monitoring, designed specifically to block the transition into end-stage failure. But there is a tipping point where a patient follows every rule, takes every pill, restricts every gram of sodium, and still experiences worsening exhaustion and shortness of breath. This marks the transition to stage D, or advanced heart failure. It is a critical threshold where standard cardiology is no longer enough to manage the disease. To diagnose advanced heart failure, doctors rely on the ESC criteria, a definitive scorecard developed by the European Society of Cardiology. The first two triggers on this scorecard are suffering persistent, severe symptoms, even at rest, combined with severe cardiac dysfunction. typically an ejection fraction that has dropped to 30% or below. The third and most critical trigger is suffering one or more hospitalizations or unplanned visits in the past 12 months that required high-dose intravenous diuretics to clear severe congestion. Hitting these criteria means the standard pill and diet strategy has officially failed to control the disease. The guidelines mandate a Class 1 response to this failure, an immediate, urgent referral to a specialized advanced heart failure team. This specialty team shifts the focus entirely away from standard medications. They assess the patient for advanced surgical therapies, like a heart transplant or an LVAD, a left ventricular assist device, which is a mechanical pump surgically implanted to help the heart push blood through the body. Given the emotional and physical weight of Stage D, the specialty team initiates palliative care to manage pain, alleviate suffering, and clarify end-of-life goals. Memorizing these ESC criteria is a matter of life and death. Waiting passively for a referral can cost a patient their final window of physical strength required to survive advanced surgical therapies. Successfully navigating heart failure means matching your current physical reality to the correct tier of these medical guidelines. If you are a stable Stage C patient, focus all your energy on Class 1 adherence. Work with your doctor to continuously optimize your foundational GDMT doses and strictly limit your daily sodium intake. Use telehealth and remote monitoring to your advantage, keeping a close eye on your weight and blood pressure to fiercely protect your current heart function and stay out of the hospital. If you are a worsening patient, recognize the ESC red flags. Stop waiting for a miracle from a minor tweak to your pill dosage. If you are facing repeated hospitalizations for congestion, actively demand a referral to an advanced specialty team. This specialty referral is not a sign that you have given up. It is a strict Class 1 medical protocol that initiates the transition to intensive, survival-focused interventions. In the complex system of heart failure management, a prescription pad is only a partial solution. Survival requires the intellectual fluency to navigate the guidelines and ruthlessly escalate your own care.